actually supposed to be a fun lecture. So we're going to finish up with the heart, talking about a little bit more about the cardiac output. And then we have to go through this interesting property of autorhythmicity. And we're going to look at some effects also of the nervous system on innervations of the heart. All right. So we started talking a little last time about the stroke volume. So we started with the basic things on the stroke volume, these things that were already on the first test, right? So these things here are actually going to show up on your Unit 2 test, right? So this is for next test, all right? So when we're talking about the stroke volume, right? So we know that there are three things that are really, really important that is going to determine how much blood is coming out of your heart. And of course, when we're talking about blood coming out of the heart, we are mainly talking about your left ventricle, because that is going towards your systemic circulation, right? And of course, you know that there is the same volume of blood that is coming out of both ventricles, because you don't want to have edema on any parts of your circulations, right? All right, so three things are important for your stroke volume. We have this thing that is preload, and then we have contractility, and then we have the afterload. So as we're going to see, when we're talking about preload, we are talking about the volume of blood that gets to the ventricle before it contracts, okay? When we're talking about the contractility, that is the intrinsic property of your myocardium. So that is how much your muscle, your heart muscle, is going to contract, the strength of that contraction to push the blood out, okay? And then when we talk here about the afterload, this is how much resistance you have that is going to try to inhibit the blood from coming out of the ventricle. So afterload is mainly the resistance that is coming from forces that are imposed by the aorta, or by forces that are imposed by a faulty valve, aortic valve. Okay, so in case you have stenosis or faulty valve function, then you can have these opposing forces that are opposing the flow of the blood. Okay, so here, more on that preload story. Okay, so when you think about preload, and this is really the amount of blood that is going to be at the ventricle before it contracts, you have to think, where is that blood coming from, right? So we know it's coming from the atria, right? And when we are looking at the entire circulation, we know that the volume of the left atria and the right atria, these are going to be the same, right? Because those volumes are going to drop in the ventricles, and that's going to, be pumped, right? But when you think about the amount of blood that is getting to the atria, now we think more about the amount of blood that was in the veins, right? So we call that a venous return. So the amount of blood that gets to the atria is the amount of blood that is going through the veins and is going to be dumped in the atria, and then that's going to be dumped in the ventricles. So this preload is really the amount of blood that is getting to the heart, all right? So this is your venous return, okay? So if you think in terms of what is happening when the heart is beating and what is happening to the volume that is getting to the heart. So let's see, if your heart is beating slowly, so it's going to have more time to fill up, and that more time is going to give you a larger volume of venous return, okay? So slow heartbeats are really going to increase the volume of venous return, okay? Besides your slow heartbeat, if you are increasing your heartbeat by exercise, okay, that is also going to increase your venous return. And we're going to see how, because this tends to be a bit counterintuitive sometimes, Okay, it really depends on the physical properties of the heart. Okay. All right, so when you have more blood coming into the heart, okay, so you're increasing this preload, is going to increase your ventricular filling up part. Okay, so what's going to happen here? When you increase your preload, you're going to increase your end diastolic volume. Remember what is the diastole? Is that relaxation. So increasing the preload is going to increase your end diastolic volume, and that is going to cause a little bit of stretch on that ventricle because you're filling up more. Okay, so you can intuitively think it's stretching that muscle a little bit more to hold more volume. Okay, so this is really what is known as the preload. So that's pretty simple, right? Pretty much intuitive. Okay, all right. Now, when you stretch your heart a little bit more, when you increase your preload, and the heart feels that stretching, what is going to happen is that the heart is going to contract with more force. Okay, so this is a property of the heart that we call the Starling's law of the heart. It's actually the Frank Starling law, so we just call it short, the Starling law. So that means the volume, the stroke volume that is going to come out of the heart is going to be proportional to your filling status. Okay, so end diastolic volume, more volume that comes in, more volume that goes out. That means more force you have to put on that heart to push that more volume out. Okay, so here you see this graph that is showing you the stroke volume that is proportional to your preload. So the more preload you have, the more stroke volume you're going to have. Okay, so if you go from normal heartbeat to an increased heartbeat, then you are going to increase preload, then you are going to also increase the stroke volume. Does that sound intuitive enough? Hopefully. Okay, so let's see here. Increase your filling up, you're going to increase the preload, and that you're going to push more blood out. Okay. Now, how do you get to increase your preload or increase your heart rate? Okay. There are several ways to increase your heart rate, but one way is through stimulation of your sympathetic nervous system, as we're going to see, in a few slides. Okay, that means if you are sending signals that are going to accelerate your heart rate, you're also going to be automatically increasing the stroke volume and the preload. So stimulatory signals via your sympathetic nervous system is going to increase your stroke volume, and of course it's going to increase your preload and your cardiac output. That's what I meant, cardiac output. Okay. All right, so here comes your first iClicker question. So the question is saying, according to the Starling law, which of the following best describes the primary relationship that leads to increase in stroke volume? So Starling law, you're stretching the heart, right? So let's see here what the options are. Increase in the heart rate leads to a proportional increase in the force of contraction. Let's see, next option. Increase in the end diastolic volume. That's your preload, right? Causes the stretching of the heart, and that is going to give you a better forceful contraction. That sounds pretty good. A decrease in peripheral resistance. We didn't even start talking about, sorry. It should be AA. If you're using the remote, I'm not sure if you need that for the app, but yeah, if you're using the remote, it should be AA. Okay. Okay, so I see. Decrease in peripheral resistance. We didn't even start talking about peripheral resistance yet, so that's a clue that most likely that's the wrong answer. Okay. Increase in parasympathetic. We just mentioned sympathetic, right? We said increase in sympathetic gives you larger stroke volume, right? We didn't talk about parasympathetic, so that's another clue that that's a wrong question. So it really should be between two answers. So the people who are giving me the wrong answers, you do have time to change your minds. Okay, one person left. Do you need more time? No, everybody send in your answers? Okay, so what is your answer? B. Okay. There's one person who kept on insisting on C. Talk to me after class. Okay. All right. Okay, so now we talk about the contractility of the heart. So that is the strength that the heart is going to contract with, right? So how strong the heartbeat is, okay? So this intrinsic property really doesn't relate much to how much the heart was stretched at first. So the contractility is the intrinsic property of that muscle contraction, okay? So how are we going to change the contractility of the heart, or how strong the heart is? You can send some sympathetic stimulation. So this is your fight or flight type of response, right? So sympathetic stimulation that can increase the amount of calcium that is going to get into your contractile fibers, right? So sympathetic stimulation is going to increase your calcium influx, and that is going to help to stabilize those cross bridges for heart contraction, right? And you remember how your contractile fibers of the heart, you remember how those work, right? You remember the action potential, right? You have depolarization, then you have the plateau, and then you have repolarization, right? So sympathetic stimulation is going to help to contract the heart, okay? Besides your sympathetic stimulation, this would be basically talking about epinephrine or norepinephrine. Okay, now my pen is not working. Okay, so your sympathetic stimulation, when you talk about sympathetic, you're thinking about epinephrine or norepinephrine. Okay, so basically that's like the same type of signal. The difference is that norepinephrine is going to come from your nerves, from central nervous system, and then your epinephrine comes from your suprarenal glands, right? Adrenal glands, okay, on top of the kidneys, okay. Now, so here, this is your sympathetic stimulation. Besides that, right, you also have other forms of input, of other forms of agents that can increase the contractility, okay? So you can have either epinephrine or norepinephrine, or you could have some drugs or some other hormones that can help with heart contraction, like thyroxine, so that's a hormone, right? Glucagon, what is glucagon? Anybody heard of glucagon before? No? That's a hormone that actually helps to control blood sugar. Okay. Then you have digitalis. What is that? That's a cardiac drug. Okay, that's a drug that used to be used for a very long time to enhance the heart contractility, but is not very much used nowadays because it ends up to be quite toxic. The side effects are not the greatest, okay? But all of these agents here, you call them positive ionotropic agents. That means it's going to increase those ions that are going to enhance the heart contraction. Okay, so what are these agents doing? They are going to increase the calcium depolarization of the heart. Okay, so they're going to increase with this effect that the muscle has to contract. Okay, so those are your positive ionotropic agents. Then on the other hand, you have some negative ionotropic agents that can slow down or diminish that force of contraction of the heart. Okay, example of those negative ionotropic agents could be if you have blood acidosis. Okay, if the pH of the blood is too acidic or is too low. Okay, pH too low, that means acidosis. Okay. On the other hand, if you have a lot of calcium in the extracellular fluids, right? This lots of calcium can interfere with the action potentials for your cardiac cells. Okay, because what is importance of calcium in the action potential? I mean the potassium in the action potential. Where does potassium come in? Well, we think about the action potential, so let's draw here the action potential. Okay, let's draw here a general action potential. You have here your threshold that is at a negative number, and then you have you have a resting membrane potential right there. Then you reach a threshold, and then you have that thing that goes up is called depolarization. And what is causing that? Okay, depends. Yeah, it depends if it is a contractile heart muscles. That is sodium current, right? Sodium current. And then you have here something that goes plateau, and what it causes the plateau? That's your calcium, that's your slow calcium. And then you have dip, and what causes that? Potassium. So potassium flowing out of this cell is going to allow for that repolarization, right? But if you already have a lot of potassium outside of the cell, your potassium from the inside of the cell, it's not going to have a big change in the gradient that is going to allow it to flow out, right? So the gradient is going to be less and less. If you don't have a big gradient, that means the flow is going to slow down. So that is going to go against contracting your heart muscles, okay? Because you're going to spend a longer time at this depolarization stage, okay? So if you have a lot of potassium outside in the extracellular fluid, now you are going to have a problem with contracting the heart muscle, all right? Does that make sense in everybody's head? Yeah. Yeah. It is held at that depolarization stage and is delaying the whole process. Yeah. Okay. And I'll tell you just as a side note, let me pause this because this is not about it, but end of life happens. Too much potassium, extracellular volume, extracellular fluid is going to stop the heart. Yep, that was her time to go. Okay. Besides that, you don't have, I mean, you don't want to be dealing with extracellular potassium all the time and stopping everybody's heart. That's not a good idea. Okay. You can use calcium channel blockers in case you have a patient who is having very fast heartbeats and you also actually need to control the heart rate. So we use these things, they're called calcium channel blockers. Have you heard of these drugs? Those are like negative ionotropic type of drugs. Okay, so you can use certain drugs to speed up the heart, or you can use some other drugs to slow down the heart. Okay, extracellular potassium is not used as a drug to slow down the heart unless you really want to slow it forever. Okay. All right, so what's the idea here? The idea here is that if you increase the force that the heart is contracting, you are going to be pumping more blood out of the heart, which automatically is going to increase your stroke volume. Okay, so is this part clear to everybody? You can increase, you can decrease, yeah. No, contractility is the strength of the heart, the strength of that heart contraction. Yeah, yeah, yeah. Okay. All right. So now we're talking about this other thing here, right? So afterload. Afterload is really the resistance that the blood is going to have when it's coming out of the ventricle. So you're basically talking here about the aortic resistance, okay, and also about the valves, right? So your aortic valve, your valve right at the aorta, right, coming out of the ventricle, that if the valve is not very flexible with the opening and closing, right? So if the valve is not very flexible, then you're going to have resistance of opening, and then you're going to have the valve that can get stuck on the open position, and you're going to have a lot more flow of blood once the aorta is pushing it to everywhere. So it has to do really with aortic and valve type of blocking, trying to block that flow of the blood. Okay, so if you increase the resistance of the blood flowing out, you are going to have less stroke volume. Of course, it's going to come out of the heart. Not a lot of the blood is going to be able to get out, right? So here are a couple of things that can increase the resistance, right? So if you have atherosclerosis, right? So atherosclerosis is hardened blood vessels. If your blood vessels are not very elastic, then your resistance to that blood flow is going to be increased. So that is going to increase your afterload. And going hand in hand with the idea of hypertension. So hypertension is increased arterial blood pressure, right? If your arterial blood pressure is always at a higher pressure than what it's supposed to be, that increases your afterload. And usually hypertension goes hand in hand with atherosclerosis, but sometimes you can have, hypertension by itself, not necessarily with the, physical changes that those blood vessels undergo in order to become atherosclerotic. Okay. So if you have lower stroke volume, that means if you look at the heart, you are going to have more volume there that didn't come out of it. So that is called your end stroke volume. So that's the volume that stayed in the heart. So that means if you have less blood coming out, you're going to have more blood left in there. Duh, that's obvious, right? But sometimes you have to think about it because you look at these arrows and these abbreviations, right? And you're like, what in the world? Oh, stroke volume, the amount is coming out. And the systolic volume is the amount that stays there after contraction. Right, so just picture that in your mind, okay? And you can do a little drawing on the test in case you don't have a drawing there already. You can do this drawing on the test and label it when you're either when you're practicing questions or when you're taking the exam. Okay. All right. So here is a picture that I find also helpful. Okay, when you're talking here about your preload, so that's the blood that gets to the heart. Here we're talking about venous return, okay? So increase preload, that has to do with a bit of stretching on the muscle, and that goes hand in hand with your Frank Starling law, right? So you stretch the muscle, you're going to increase the force of contraction, okay? On the other hand here, if you have your afterload, that's the resistance to the blood coming out, right? So you can also relate that to a decrease stroke volume. Okay. Hello. All right. So what are factors here that are important in determining your cardiac output, right? So we see here that if you have a certain stimulus like exercise, for example, right? So when you are exercising, let's talk about exercise first, is the easiest one, right? Let's say also if you are very anxious, or if you are afraid, or if you go into this flight or fight or flight situation, right? Mainly you're going to increase your levels of epinephrine and norepinephrine. That means you're going to enhance your sympathetic activity. If you enhance sympathetic responses, that means you're going to increase your heart rate. Sympathetic is always increasing your heart rate. And that's very intuitive, right? Because if you think about, epinephrine, and you're thinking about a fight or flight situation, and you look at a person that is in this anxious state, you are not expecting to see somebody who's just relaxed and chilling out and like, hey, bro, what are you expecting to see? Somebody who is like looking like a bit pale, and if you check on their heart rate, you can almost hear their heart beating, right? You know those movies, like you see somebody really afraid and they put in the background, and then your heart rate starts to go up because you're watching somebody being in that situation. You know what I mean? That's all sympathetic stimulation. Okay. So increase heart rate, what is going to happen? You're going to increase contractility, and your stroke volume. Eventually everything here goes to increased cardiac output, right? So you can follow this chart here and make sure you understand what is going on, okay? Okay, another thing here that is interesting, when you increase your sympathetic activity, you automatically decrease your parasympathetic activity, because those are opposing type of stimuli, okay, opposing types. If you increase sympathetic, you're going to decrease your parasympathetic. If you decrease your sympathetic, you're automatically going to have increased or higher parasympathetic effects, okay? All right. So that brings us to this conduction system that we have briefly seen before, but now we're going to see into more details because I had not mentioned before this self-firing cells. Okay, so what is happening here? Well, we know that the heart has its own electrical circuit going on, right? And we know that the heart can beat on its own, right? Doesn't need input from the central nervous system in order for it to function, right? Did anybody here watch those series? What's the name of it? Grey's Anatomy. Yeah. I made a mistake of starting to watch Grey's Anatomy, and then I couldn't stop. And then I realized there were like 20-something seasons to it. That was like torture because I had to finish watching it. And but then there was one episode that they had this heart in the box type of thing. You know what I'm talking about? The heart. So they had this beating heart like in the box. And I was like, oh, that is so cool. And it actually, most of the information there that I could catch, it was quite accurate. And it was showing, the heart is beating on its own. And this is why you have cells in the heart that can depolarize and generate their own action potential without input from anywhere else. These cells will do everything on their own. Okay, so where are you going to find these cells? you have these cells at these nodes. Okay, so you have your sinoatrial node that is on top here of your right atria. Okay, then you have a connection here that goes to the atrioventricular node that is also on the right atria, but it's just before this division with the ventricles. Okay, so after that you have these fibers that will go down. You have this bundle, or you call the bundle of His, or it's also called the AV bundle, that goes right in the middle here, the heart septum. Okay, so you have this AV bundle, and then you have these fibers that go all the way down to the apex of the heart, right? And then they go up the ventricles. When they diverge here from the apex, you call those Purkinje fibers. So these cells here are going to transmit the action potential that is going to go slowly from this side to that side all the way down, and then get your heart to start contracting from the bottom up. Okay, so those Purkinje fibers are going to send electrical signals for the ventricle, for the both ventricles to undergo that syncytial contraction, right? So here you have at the atria, you have your SA and AV nodes that basically your SA node here that coordinate the atria syncytial contraction. Then these impulses slowly going to shift down, and then you have your ventricles that are going to contract. Okay? So this is all this intrinsic and autonomous type of conduction. All right, so the autorhythmicity. Okay, so we know that like if you see a heart that is transplanted, you don't really have to connect the nerves in order for the heart to work. Okay, so this is a part that is very, very cool about this pacemaker cells. All right, so how many of those cells do you have in the heart? Well, actually a lot. Look at this, about 1% of the cells are this type of pacemaker cells. Okay, those cells, they're conducting electricity, but themselves they do not contract. All right, so remember in the heart you have the contractile fibers, and now you see the pacemaker fibers. All right, so these guys do not contract. Okay, so what is happening here is that these cells are going to fire their own action potentials, right? And there is a specific way on how that thing happens, right? So they are connected, they have these electrical connections, right? So they're going to send action potential from here, that's going to travel and stimulate action potential of these other cells, and that's going to travel all the way down, and then you have all the cells that are sending out this electrical signal. So this entire system here is what you call your conducting system of the heart. Okay, and how are the cells connected? They have the gap junctions. All right, so the cells are communicating with each other, and by the time they get to the contractile fibers, then you're going to have those gap junctions that send the action potential and allow the contractile fibers to actually also depolarize. All right. So here is a picture showing two cells. So this top one here is one cell, the bottom here is another cell. So between the two cells, you see those little connections that are your gap junctions. Okay. All right. So here, okay, this is, I just mentioned that. Okay, so here we're going to talk about those sinoatrial node. Okay, the cells in that node. All right, so here your sinoatrial node. Okay, remember it is right at the top of your right atrium. Okay, and it's going to fire an average 70 to 80 times a minute. That's a normal heart rate. I think that's a bit elevated, but yeah, that's usually the firing of the SA node. Okay. So SA node is the most important one, is going to set the pace for the rest of the heart. The nodal delay. Okay, so delay of that signal to be sent to the Purkinje fibers. Because if you don't delay, then you're going to have problems. Okay. All right. All right. So then you send the delay, you pass through the AV node, and then you're going to reach your bundle of His that bifurcates. Okay. So you have your bundle of His that bifurcates, and then you're going to have your slowest fibers. Okay. That these guys here, they can also depolarize on their own, but they are not really as important as the other pacemakers. They are faster. Okay, so you have fastest, kind of fast, and slow type of fibers that depolarize. So those, how often do they depolarize? You see here, 20 to 40 action potentials a minute. Okay, so let's say that if everything goes well in your heart, so your SA node is really calling the shots here. If your SA node fails, then your AV node is going to call in the shots, and your heart can work just well. Now, if your AV node also fails, now you have these other fibers that can depolarize, but now you have a problem, because if either of these nodes do not send a signal, these guys here are not sufficient to keep the heart pumping. Okay, yeah.
You also lose the atrial kick in that situation?
Yes, good observation. If those are not working, you lose the atrial kick. You know, you can survive without the atrial kick, but you cannot survive without the heartbeat at all. Okay, so yeah, you can deal without the atrial kick, but if your ventricles do not kick, then you kick the bucket, right? So not good. All right. So firing of those lower fibers, that is not enough to keep the heart pumping. Okay. So here, not life-sustaining. All right. Okay, so now really, how is it that those fibers are doing it, right? How these fibers, they are not contracting, how is it that they are serving as pacemakers, right? So they have very cool ion channels. And you have this thing that is called it's actually called a funny current. Okay, it's called a funny current. That has to do with positive ions that leak out of the cell. Okay, so what happens with this ion funny current is mainly sodium. It's mainly a sodium current that is going to flow. Where does sodium flow? Is it coming into the cell or is it going out of the cell? Okay, I should make it more specific. Your sodium-potassium pump gets your membrane to be at resting potential, right, which is relatively negative, okay, resting potential. Then, just when you're going to get an action potential, what happens to the sodium current? So here's your cell. Then here you have your sodium-potassium pump that is doing what? 3 sodiums out, right? And 2 potassiums in. So sodium-potassium pump is establishing your resting membrane potential by kicking sodium out. Now let's say that you are going to have an action potential, and when this action potential depolarizes, the inside of the cell that is more negative gets a flush of sodium, and this is how you depolarize your membrane potential, right? Sodium current in. All right. This current right here is going to depolarize. If you look at every other cell, this is how it behaves. When you look at pacemaker cells, this resting potential and sodium influx, it doesn't look like that. It looks different. The sodium channels are leaky. Okay, so you have here with your pacemaker cells, you have here, let's put it here, some channels, some sodium channels that are leaky. It means they are not totally closed. Okay, so sodium that accumulates outside gets to leak back into the inside of the cell. Okay, so now if you look at your resting potential and you have a constant leakage of this sodium, then this resting potential is not going to be resting a long time. It's going to be, it starts to rest, but then it starts to go up like this because you have that leakage channel. Sodium is always leaking inside, so you are not very negative here all the time. You have some positive ions that are getting in there. So your overall membrane potential is increasing, okay? And then it reaches threshold, and then whoop, you have your action potential, okay? Now this action potential is not going to be a total influx of sodium. The action potential is also actually going to be caused by an influx of calcium. Fast calcium influx, okay? So a fast calcium influx is going to give you that action potential for these pacemaker cells. Okay? So that influx is going to go up here, and then you're going to have a bit of plateau, and then you're going to go down. How you're going to get the repolarization? By efflux of potassium. Okay? So here you're going to have your funny current. It's funny, it doesn't stay down there. And then you're going to have mainly calcium influx for your depolarization, and then you're going to have your potassium for your repolarization. Yeah. Is not the same, no. We do have the next one here. Right there. This is it. Okay, okay. So the question was, do you also see a plateau here? No, these guys are not your contractile fibers. Those get it. These guys are not contracting. They're just firing. Okay? So look what happens here. You have here what would be your resting potential, but look how this is curved. Okay, you don't have a flat line here for resting potential. It doesn't really rest. So you repolarize. As soon as you repolarize, it's like it's not quiet. You have leakage of that sodium channel. Okay, then you reach threshold and action potential, then repolarization, and here we go, leakage thing. This is your pacemaker potential. So this is what you call this is due to that funny current. Okay. So we always do here a bit of a class exercise depicting what the funny current is. So this, yeah, the third of the class here. So we still have a wave effect. So we always start here with the funny part, the funny current. Oh. Am I going to ask you about this in the test? Yes. I know it's difficult. That's the nature of the beast. It's not my fault. Okay. All right, so depolarization happens because of fast calcium current, right? Repolarization here is because your potassium efflux. All right. So here's a better picture of your funny current. Okay, fire, fire. Okay, this only happens to pacemaker cells. This is why they are spontaneous. Okay, firing is just spontaneous once they reach the threshold. All right, so here is your funny current that has to do with sodium, right? And everything else, okay, everything is the same as before, okay. All right, so just for you to read, and here more of a visual on what is happening with the channels and with the currents. Okay. Okay, and another question. Okay. Cardiac muscle cells have several similarities with skeletal muscle cells. Which of the following is not a similarity? Do we need more time? I thought it was. All right, so here, that also has to do with hormones. Okay, so here. So we gotta know how this electricity is flowing. Okay, you gotta know what is happening in the heart, where the electrical signal starts. You know you're gonna start here at the SA node. It's gonna travel here to your AV node. Then it's gonna go down the bundle of His. It's gonna go through this bundle of branches here, and then you're gonna go Purkinje fibers, and that's the story. Okay. So if I ask you something that, what is the sequence of pacemaker cell excitation in the heart, and then you should find what's the correct sequence, right? That's always a good test question. Okay. All right. So here I just put in words what I had just mentioned before, okay, and how quickly those are the fast pacemaker cells, right? And here, what is happening here? Relating that to your funny current, okay? If you have stimulation from your central nervous system, that is going to increase your heart rate. So let's make a little drawing here, okay? So here would be regular action potential using your funny current right there, okay? Well, you should not increase in amplitude, okay? So here is your funny current, here is your funny current. Now this, let's say that this is your regular heart rate, okay? So let's say now that you want to increase your heart rate. What do you think would have to happen with your funny current? Let's see here. You would have to make it faster. Faster funny current. So that is going to increase your heart rate. So if you have positive ionotropic factors that are bathing your cells, then you are going to make those leakage sodium currents leak a lot more. Okay, so if you open up those channels, you're going to have a lot more sodium that can get in the cell, and you're going to reach your threshold and depolarization, a lot faster. So positive ionotropic factors act on that funny current and increase your heart rate. Okay? On the other hand, if you stretch out, making these sodium channels less leaky, that's how you slow down your heart rate. Okay? So it really depends on what is happening with those leakage channels. Are you leaking more or less sodium? Okay? So when you look at the regular heart rhythm, you call that your regular sinus rhythm. Okay? So without increasing or decreasing. Okay? All right. So here is a big picture on your AV node that is going to connect with the bundle, right? Bundle his, or they call it AV bundle, the same thing, okay? So what is happening here? This is the guy that is slower, and this is the guy that put that delay from the initial signal to the signal that is going to go down to the ventricles, okay? So this delay is really, really important to allow full atrial contraction, and then later, after 0.1 second, you're going to send in the signal for the ventricular contraction. Now, this here, the AV node, especially here the bundle, that's the only point, the only sites of connection between your atria and your ventricle electricity. Okay, so the only electrical connection, because remember you have that insulating part at the level of your valves, right, of your AV valves. You have all that collagen that is insulating the electrical signal, right? So the AV node and bundle, especially the bundle, that is the only here, the bundle, okay? This is the only connection between the atria and the ventricles, okay? If you cut that, then you're not going to have the impulse that goes down to the rest of the heart. Okay, so a bit more here on your Purkinje fibers. Let me see. Okay, so this is also called subendocardial conducting network. It's a lot easier just to remember Purkinje fibers. Okay, so we mentioned that already. Okay, so here's a whole picture of the heart and all this conduction business. So here is a nice graph that puts together what is happening time-wise with those action potentials. All right, so here is your SA node action potential. Here's your funny current right there, and then firing. Okay, after you fire, you are going to have your syncytia of your atria that is going to depolarize. So after this guy fires, now you have depolarization and contraction of your atria. And here is where you have that delay, okay? You have a delay. And now you're going to have your AV node firing, okay? Remember, the AV node can also fire on its own in case SA is not working. So it also has that delayed funny current, okay? So you have here firing of the AV node, further delay, and contraction here of your ventricular fibers, contractile fibers. Okay, so look at the time here, difference. And what is causing the delay here is the bundle of His. That is the important connection here to cause the delay. I mean the bundle of His that goes down after the AV node. It's always good to draw these things out because a lot of stuff to remember, right? Okay. All right, so everybody's cool with all this conductivity of the heart? Okay, so now we're going to talk a little bit about the autonomic nervous system. All right, so what is happening with all those nerves that are connecting to the heart? Okay, so you have your sympathetic nerves, and you also have your parasympathetic nerves that are going to connect, especially with your SA and AV nodes. Okay, so what are these nerves going to do? They want to control three things. They want to control blood pressure and blood flow and also blood volume. Okay, so pressure, flow, and volume. So signals from your central nervous system, they are going to come out of this place that is at the medulla, right on top of your spinal cord. Okay, and you have a place in the medulla that is called your cardiovascular center. Cranial nerve 10, that one goes straight from the medulla all the way down to organs that it innervates. Okay. All right, so what is happening here? So look what is going on here. I modified this figure from the book because I thought the figure was too busy. So I tried to make it simple, okay? So here you have at the medulla, you have here your cardiovascular center, okay? So you have your inhibitory center that I put on red here, and then you have your acceleratory center. Okay, so look at this. Your inhibitory center, you have a nerve that goes straight from the medulla and goes straight to the heart. So this is your vagus nerve. And what is the vagus nerve innervating? It goes straight into the SA and also at the AV node. So you have both of those nodes getting innervated by your vagus nerve. So that is for your parasympathetic. Okay, so this guy is your parasympathetic right there. All right, so look here at your acceleratory center. Now the path is different. It goes from the medulla down to the spinal cord, and then at the level of your thoracic spinal cord, you are going to have nerves that are going to come out, and they are going to innervate, oh, surprise, SA and AV node. And also some of those Purkinje fibers down there. Okay, so sympathetic, it goes to the two centers and also down at the ventricles. You have more sympathetic innervation. Okay. All right, so here just in words what I mentioned. And important things to know. Your acceleratory center, most important neurotransmitters are norepinephrine and epinephrine. So of course that is going to increase your heart rate. Okay. Norepinephrine and epinephrine, they are going to bind to certain receptors in your heart. The receptors that respond to those neurotransmitters or hormones, bless you, those are called beta adrenergic receptors. So if you stimulate your beta adrenergic receptors, what's going to happen to your heart? All at once. Everybody falls asleep. Too much parasympathetic activity. This is your sympathetic guy. What's going to happen to your heart? Goes up. Goes up. Right? Heart rate goes up with stimulation of beta adrenergic receptor. So now let's say that you have a heart problem, that you have accelerated heart rates, and you don't want that because that's detrimental to your health overall, right? All the time, right? So you can use some drugs to slow down your heart rate, and those are your beta blockers. You heard of beta blockers? So those are going to block the action of norepinephrine and or epinephrine, and those center at the SA and AV nodes. Those are your beta blockers. Okay. All right. So here, what happens if you are increasing your sympathetic activity? You're going to increase your stroke volume. You're going to increase your cardiac output up to a certain level. You don't want to increase your heart rate way too much. Otherwise, that is going to become pathological tachycardia, right? If you increase your heart rate way too much, I think it's more like 190, not 160, ready? Because 160 is still okay, right? But if you increase it way too much, now you're going to have problems, because you are not going to have enough time for your heart to fill up. So your cardiac output is going to go down, okay? So it's going to be actually not an effective way of increasing stroke volume or cardiac output if your rate goes way too high. Okay, does that make sense? Yeah. Okay. All right. So a bit at your cardio inhibitory center. Okay, actually this is the last slide, which is like just in time. Yeah. Okay. So cardio inhibitory center is also at the medulla, right? Remember that goes through your vagus nerve, right? Cranial nerve 10. This vagus nerve works with one very important neurotransmitter, that is acetylcholine. Okay? So what is acetylcholine going to do to your heart? Okay. Remember when we mentioned epinephrine or norepinephrine, it is increasing your funny current. So now acetylcholine is not actually going to work with your funny current, it's going to work with something else. Okay, look at this. It is going to hyperpolarize. What does hyperpolarize mean? Let's look here. Okay, so let's see here your pacemaker cells at your regular funny current and firing, funny current and firing. Now, let's look here at a hyperpolarized. So now what you're going to do is hyperpolarize, here funny current and then fire. Hyper. So now you push down what is supposed to be a resting membrane potential. So your funny current is the same as before, but it's going to take a lot longer for it to reach your threshold. Isn't that a clever mechanism? Right? So now, if you hyperpolarize, first, how is it that you're going to hyperpolarize this thing? If you open potassium channels, potassium, where's potassium? You got to always think about this stuff, right? Sodium potassium pump, sodium out, potassium in. So potassium is inside of the cell and is positive. If you open potassium channels, potassium is going to go out. So the inside of the cell is going to be more negative. Oh, that makes sense. Hyperpolarizing means you start at a resting potential that is more negative. So it's going to take a lot of funny stuff for this thing to reach threshold for action potential. Opening those potassium channels is the job of acetylcholine that is coming out of the nerve, of your vagus nerve, okay? Parasympathetic vagus nerve. So you hyperpolarize this thing. It's going to take longer for the funny current to do its business, and you're going to space out your action potentials. Does that make sense? This takes brain power, right? You got to know what is happening with the channels, with the currents, with the nerves, where these nerves are, where the centers of the CNS are, and what those neurotransmitters are doing. Okay, so now what do you do after this class? Okay. You enhance your parasympathetic function. It helps with long-term memory and recall. Okay.